Hello and welcome to the Point of Care podcast. Today's topic is hypotension, running a rapid response. When you walk into the room, your first impression should focus on the patient's mental status, whether they're in acute distress, and their general appearance. Note any tachypnea or increased work of breathing, including nasal flaring, retraction, tripoding, or cyanosis, and ask yourself if the patient is protecting their airway. Check to see the last few blood pressures and the timing on the monitor. Ask where's the BP cuff and can we trust the readings that we're getting. Look into their current oxygenation. What are they currently hooked up to? Are they getting better? And are you worried that you might need to intubate? For initial stabilization, if the patient's not responsive, check their pulse. If they don't have one, start the ACLS algorithm. Also, consider whether or not they need to be intubated. If they're in respiratory distress or hypoxic, put them on a non-rebreather and put it up to 100% FiO2. If they have an arrhythmia, like AFib, and the heart rate is greater than 150 to 170 and they're hypotensive, it could be the heart rate that's causing the low BP. But if it's less than 150, the hypotension and the illness is probably causing the AFib. If they have a GI bleed, consider the need for a massive transfusion protocol. And in the case where it's undifferentiated hypotension, give LR, send a basic and infectious workup, and start or broaden antibiotics. Think about whether you need pressor, usually starting with Levophed, if you need it, and consider giving calcium gluconate or stress dose steroids. The first things you should be asking about after that initial stabilization is the reason they're in the hospital, their relevant comorbidities, their baseline mental status and BP range, the acuity of the change in hypotension, recent meds or procedures they've had, current access, code status, and decision makers. On your exam, look at their vitals. Note whether they're febrile. Note their BP trend, their heart rate, oxygenation, and respiratory rate. On exam, you can look for cap refill. For POCUS, you can look at their heart to evaluate for tamponade, RV failure, and LV function. You can also evaluate their lungs to look for a pneumothorax or any evidence of edema, and you can also look for their IVC to whether they're in a volume overloaded state or if they're potentially dehydrated. Some red flags that might suggest you need to intubate the patient on the earlier side include pooling secretions, hemoptysis, or respiratory distress. When you're thinking of your workup for why a patient's hypotensive, think about infections. Send a CBC with diff, get a chest x-ray, a UA with urine culture, a blood culture, and a lactate to see whether they're in shock. For metabolic etiologies, send a CMP to look for calcium and end organ damage. Consider a TSH and cortisol. For toxins, check the MAR to see if they're on opioids, anticoagulation, which might suggest they can have a worsening bleed, if they're on beta blockers or calcium channel blockers, or TCAs, in which case you might need to give bicarb. If they're hypoxic, get an ABG or a VBG, and on that you can also check their hemoglobin and their iCal. If there's concern for ischemia, get an EKG, a troponin, and an NT-proBNP. And if there's any concern that the patient might have a PE as the etiology of their hypotension, a CT-PE can be considered. The differential includes vasodilatory, which includes sepsis, anaphylaxis, and neurogenic shock. The next is hypovolemic. One of the causes is hemorrhage, and the places in your body where you can have significant blood loss into or out of is the GI tract, into the thoracic cavity, your abdomen, your retroperitoneum, and your thighs. If you're on diuretics, that could also cause you to be hypovolemic if you have poor PO intake or if you have significant vomiting or diarrhea. The next is cardiogenic causes. This can be caused by an arrhythmia, an ischemia or MI, and valvulopathy. Obstructive is next, and that could be caused by tension pneumothorax, a pulmonary embolism, or cardiac tamponade. Toxicologic etiologies include opiates, sedation, beta blockers and calcium channel blockers and TCAs, and then metabolic causes, which include adrenal crises and hypo and hyperthyroidism. Some general questions to ask yourself. First, is this hypotension driven by a loss of cardiac output or loss of systemic vascular resistance? Next, ask yourself, is this patient in shock? If so, which kind is it? Is it distributive, hypovolemic, cardiogenic, or obstructive. And POCUS, as we discussed, is a great way to be able to distinguish between a lot of those. The next question is asking, what is this patient's preload? Get a sense of their volume status, their venous return, their tone, and obstruction to return, like a tension pneumo or tamponade. Next, you can ask, what's the patient's contractility? How hard is their heart squeezing? Next, what is the patient's afterload? Thinking about SVR, arterial stiffness, obstruction to flow, like aortic valve calcification or HOCM. And then lastly, is this patient likely to be fluid responsive? And that would be if the patient is hypovolemic and sepsis. And in general, you can almost always start with a small bolus to see whether or not they are. That's all for this episode. Check out pointofcaremedicine.com to see the templates we discussed, as well as the pearls, literature, and links to other resources.